So I will present you today acquired copper deficiency in patients with and without Wilson disease. As all of you know, copper is a very essential trace element. It is brought in our daily diet. It is essential as it acts as a cofactor for many enzymes, which are very important for playing a role in fundamental normal functioning of many organs, and more particularly neurological systems and hematological systems. As you know, some cases of acquired copper deficiency has already been described. It's remained rare, but it's certainly misdiagnosis. It is important to know as it is a treatable deficiency and a treatable cause of reversible myelodysplasia and myelopathy. There are two main different mechanisms implied in acquired copper deficiency, the one which are related to Wilson disease and the one who are not related to Wilson disease. We will see later all these causes. The main objective of this talk was to review all the cases of ACD, the one with neurological symptoms in patients who did not have Wilson disease, and the cases of ACD in patients with Wilson disease. And we were very interested in comparing ACD in patients with or without Wilson disease. To do this study, we searched in the Toulouse and Lariboisière registries, which collect all the copper trace element disease, all the cases of ACD which were reporting within the last 7 years. This report were very well detailed, and we were able to focus our attention on the neurological examination, electrophysiological data, the MRI, both of the brain and the spinal cord. We had a good biological description and toxicological screening. And we were very interested in having a look to the treatment which were proposed and the evolution of this clinical, biological, and imagical patient at last follow-up. So the results were that we were able to identify 10 patients who had ACD within the last 7 years. 7 of them had not Wilson disease, and 3 had Wilson disease. They had in the both group the same age at diagnosis of ACD. They were around 70 years old. But the first point, which is already interesting to notice, that it took quite a long time to diagnose, 6 months for the patient without Wilson disease, but it was much more longer, also 12 months mainly for the patient with Wilson disease. We will have to discuss this point later. First, let's focus on the patient with ACD, but without Wilson disease. These patients were all symptomatic with neurologic symptoms, and they had all sensory ataxic gait. All of them but one had paresthesia. All experimented posterior cord syndrome at examination, and 3 were more severe with subacute combined degeneration. This patient had brain and spine MRI. 4 of them had normal spine MRI, but 3 of them had normal spine MRI. And the patient who had abnormal spine MRI, we noticed, as it is classically described, I don't know if you can, sorry, it's not light, there is not light enough. We were able to see there was an extended posterior cervical and thoracic spinal cord hyper-T2 signal on the MRI, but without contrast enhancement. On the brain, 4 patients had normal brain, but 3 had widespread white matter, T2 and flare hypersignal on this exam. Electroneuromyography was available in 6 patients, and it showed in most of the patients neuropathy. Both it was either demyelinating or axonal. On the general biology, we were able to identify anemia in all the patients but 1, and also a mild lymphopenia in out of 7 of the patients. As expected, all the other causes of spinal cord syndrome was negative. Serum copper in all these patients was severely decreased as the ceruloplasmin. But urinary copper expression was normal in all. In 4 patients, we will see the reason why we were able to identify serum and urinary zinc high in this patient, and we will see that it was a patient who used dental cream adhesive with a lot of zinc inside. And we will see later that it was interesting to notice that this patient had normal iron level. So let's have a look to the cause of ICD in this patient without Wilson disease. 2 main causes could be identified. As I said a little bit earlier, some of them, 4 of them, used chronic dental cream, which was enriched in zinc. And zinc is able to activate a metallothionein protein, which will link the copper, which is brought by of the food, and it will act as a as a chelation agent, and so zinc copper will not be able to be absorbed either in the saliva or in the mucosa digestive. The second cause was malabsorption syndrome secondary to surgery, either gastrectomy, esophagectomy with a jejunostomy, and 1 patient had bariatric surgery. She was recommended to have vitaminic supplementation, but she stopped it 4 years before the onset of the symptom. And 1 patient had the association of the 2 causes. For the treatment, it was a little difficult because there is no recommendation. We choose to perform an acute treatment with copper histidine subcutaneous during 5 days, mainly, and we keep the treatment with oral prolonged supplementation by copper oligosol at a mean dose of 1.6 milligram per day. At the last follow-up, all the patients but 1 were still on treatment. The one who stopped the treatment stopped after 7 months of treatment as he fully recovered, and he stopped the use of denture adhesive paste. The evolution of this patient was quite good. After the first month, copper balanced normalized, and a little bit later, anemia and lymphopenia, which was also observed, normalized. It took at least 10 months to normalize both the MRI for all the patients. While this examination normalized, the patients were still symptomatic, and we had to wait for 2 years mainly to notice that all the patients improved. 2 out of 7 had a normal neurological examination at this follow-up at 2 years after the diagnosis, but they keep complaining about transient subjective paresthesia. 4 of the 7 other patients of the remaining patients improved their gait and balance. They had less paresthesia, but they keep having a moderate posterior caudal cord syndrome at examination, but they were much more improved. For the Wilson patient, only 3 patients in a registry were identified. It's only 1% of the patient. It is interesting to notice that the patient has the age of the diagnosis of Wilson disease were older than the patient we are used to diagnose this Wilson disease, as the patient with ICD in Wilson disease were mainly 38 years old, while the patient in the registry at the moment of the diagnostic were only 18. The reason why they were diagnosed later is maybe because they have a less severe disease than the younger one. One was diagnosed when he had no symptom. He was totally asymptomatic, and it was diagnosed on a familial screening. The 2 other one had mild cirrhosis. One was associated with Kaiser-Fleischer ring, and the other one had an isolated right cramp, which is difficult to make a link, but we are not sure about the link with the Wilson disease. Interestingly, other patients had brain MRI normal, and what is very important to notice that they received the classical treatment for Wilson disease. The patient who was asymptomatic only received zinc acetate, but it was during 6 years. And the 2 others who had cirrhosis received chelating agent for a long time, and as they had a great improvement and in order to decrease the problem of tolerance of Toradol, they will switch for either acetate agent alone or triantine plus acetate, zinc sulfate. And what is the common point for the 3 patients, that they all receive zinc for more than 6 years. ACD in this patient occur between 6 years after the onset of the disease, and for the last patient, 33 years, mainly 70 years after the initiation of Wilson disease treatment. As I said earlier, it took quite a long time to diagnose ACD in this patient, too much more time than for the patient ACD without Wilson disease, as it took 12 months. The presentation of ACD in this Wilson disease was for the asymptomatic patient isolated pancytopenia. He had a sore infection, and it was pancytopenia was diagnosed. And the 2 other one who had cirrhosis at onset of the Wilson disease developed neurological symptom, while they didn't have any neurological symptom during the course of the Wilson disease. They were both having progressive ataxic gait with paresthesia, and they had posterior cord syndrome at examination. None of them had subacute combined syndrome. In both the patient, brain and spinal cord MRI were normal, as electroneuromyography. In one patient, pancytopenia was identified, but what is very interesting is that anemia was found in all the patients. Serum copper, exchanger copper, and urinary copper expression was very low in this patient, much more lower than expected in the patient treated with Wilson disease treatment. As they were treated with zinc, serum and urinary zinc value were also high. And what is very interesting is that serum iron levels were all low, all- low serum iron, high transferrin, a low coefficient of saturation of the transferrin. When ACD in this patient was identified, we thought it was not possible to bring copper. So we decided to decrease for one patient of two-thirds the dosage of the zinc acetate. We decided for the patient who was totally asymptomatic, who were identified with the screening, familial screening, to stop the treatment. And for the other who had triantine plus zinc, to stop triantine and to decrease the dosage of zinc. 2 out of 3 of the patients received iron supplementation. The patient who had neurological symptoms improved slowly but surely. They had at 31-month follow-up an objective neurological improvement. They keep on having paresthesia, but the examination was nearly normal. Hematological disturbance and iron deficiency were resolved in 2 of 3 of the patients. As expected, exchanger copper value were still low, and urinary copper excretion started to increase. We wanted to report the ICD as it is exceptional in our country, but it is surely misdiagnosis. First manifestation are usually hematological one, but we sometimes the link with the copper deficiency is not made. So ACD can be revealed by neurological presentation, and we saw that there are some cases. It's remained rare, but it was already reported in some recent cases, and the most important was the Scottish one, who identified in the same period 12 ACD patients with neurological symptoms. What is important to know, it's a neurological presentation of ACD mimics a vitamin B12 deficiency with posterior cordonal syndrome, leading to a sensory ataxic gait that can extend to a subacute combined degeneration. Imaging can be strictly normal in some patients, even if they have neurological presentation. But it can also abnormal white matter signal, and the mechanism could be a failure of myelin maintenance due to a dysfunction of the methylation cycle, which requires copper. It can explain the lesion. The cause of ACD are digestive in patients who are not Wilson disease, and attention must be drawn of patients who had extensive digestive surgery and on patients who had bariatric surgery. Then they must not stop their vitaminic supplementation. In patients without Wilson disease, also excess of zinc intake, secondary to use of dental cream enriched in zinc, must be thought. In Wilson disease, the prolonged treatment by zinc salt is mainly the cause of ACD, and it was reported to appear after 6 years, and in the Polish experience it was also reported to occur between 5 and 16 years. Maybe there are more patients, Wilson disease patients, who are most exposed to develop ACD. maybe the patient who have late form of Wilson disease, maybe with a less severe Wilson disease, with a less severe load of copper in the organ. They were all treated by zinc. It is recommended to treat patients with less severe with zinc because of less side events. But we must keep in mind that with zinc, ACD can occur, and a special follow-up must be performed. ACD with Wilson disease might be associating with iron deficiency and associated with an anemia, but the mechanism remains to be explained. The treatment is not well known. It's based on non-Wilson disease on copper supplementation, but guidelines need to be performed. And for Wilson disease, the decrease or discontinuation of the zinc salt plus iron supplementation could be a good way to treat ACD. The neurologic symptom will get improved, but very slowly. In conclusion, copper deficiency in Wilson disease is rare, but has to be known. Regular follow-up with clinical and biological evaluation is needed to adjust treatment and prevent ACD in this patient. Worsening of gait disorder should alert, and when PCS at examination is constated, it should evoke a copper deficiency. And when urinary copper excretion is very low, when we notice anemia or leukopenia in this patient, and when we notice iron deficiency, we must think about ACD in Wilson patient. The mechanism of iron deficiency remains to be found. Thank you for your attention.